Miami com o Bernardo em Coral Gables e esperando estar em Brasília os dias 15, 16 e 17 de junho.
Puxa, que bom, que coisa boa. Viu?
E depois agosto, né? Vamos lá em São Paulo.
Você vai conseguir ir lá na Sobramide? Você já viu?
Eu acho que sim.
Ó, você precisa me falar para eu acertar a sua passagem.
Tá bem. Falamos mais tarde sobre isso. Vai ser em São Paulo,
claro,
né?
Claro.
Vai ser em São Paulo?
É em São Paulo. São Paulo.
Tá bem.
Exato.
Tá bem.
São Paulo. De 3 a 5 de agosto, Stanley.
3, 5 de agosto. Tá bem.
Isso.
3, 5. Então, não vai ser o 11, não vai ser o 11, 9, não vai ser 9, 10, 11, não.
Então, essa foi a proposta que eu te liguei aquela vez para te fazer.
Sim.
Para a gente fazer o lançamento no congresso do livro, no Congresso da Sobramide.
Perfeito. Então, 3 a 5.
Exato.
Terça-feira, quinta-feira ou sábado.
Isso, exato.
Tá bem. Falamos mais em frente. Perfeito.
Sim, sem problema. Tá bem. E o seu amigo passou bem lá do coração?
Sim. Me escreveu até hoje que está sentindo muito melhor e já está recuperando. Primeiro foi admitido para um AICD defibrillator, mas, sabe, as coisas passam não tão bem para médicos e enfermeiras, né? 3 dias depois, tiraram 1.900 cc de sangue de um hemothorax que causou perfuração do eletrodo no coração dele. Então, imagina, rapaz, não estava sentindo bem, não podia respirar, sentia bem frágil e foi para o hospital, a placa estava completamente branca.
Nossa.
E tiraram 1.900 cc de sangue. Pô,
meu Deus do céu, como que ele não morreu, Stanley? Que sorte.
Exatamente.
Meu Deus do céu.
You know, a cardiac tamponade with a hemothorax causes severe decompression of the compensation of the blood vessels. Imagina isso, né? Imagina isso.
Uma loucura. Que loucura.
Que loucura. Mas agora as coisas melhoram, não? Estamos aqui
Opa! Sim, eu estou aqui, ó.
Que bom. Quem é que deu essa originação para combinar vinho e dor?
Eu copiei, nada se inventa, né? Eu copiei, existe uma reunião famosa que chama-se Spine Wine.
Ok.
Spine Wine é o grupo da coluna, e eu pedi autorização para eles, são amigos meus aí, para me autorizarem a fazer, a ideia foi minha, né? Fazer o Pen Wine.
Lógico.
E é muito agradável, Stanley, porque a gente fala um lado social também, né? Conta um pouquinho de uma história de um vinho.
Lógico.
Ficou maravilhoso. Nós já trouxemos, está disponível na internet. Nós já trouxemos, às vezes o palestrante, ele tem um enólogo amigo. Então ele traz o enólogo para falar no lugar dele sobre aquela introdução do vinho. Então nós já tivemos um franco-brasileiro, que é um colega que mora na Borgonha, ele é brasileiro por parte de mãe, é igual você aí, amigo. E ele é dono de uma vinícola na Borgonha, ele falou para a gente aqui. Veio também uma enóloga da Espanha e nós temos ainda aí alguns outros aí que também... Então fica um lado onde fala um pouquinho do social.
Lógico.
E traz também a parte do vinho. Né?
Puxa, isso é uma coisa fantástica.
Não é fantástico?
Honestamente, não podia ser melhor com cerveja e vinho, mas não, isso é fantástico.
Sim.
Que bom.
E a nossa ideia é, por exemplo, nos eventos da Sobramide, por exemplo, o Congresso Brasileiro, encerrar com uma discussão de casos, mas quem tiver na plateia, a gente vai servir vinhos na plateia.
Que bom.
Não, sim.
Que bom. Uau.
Não, maravilhoso.
Esperamos falar bastante coisas muito bom com vinho e depois falar sobre o mild procedure.
Perfeito, perfeito. Como que está a temperatura aí, Stanley? Tá bem?
Tá quente, tá quente. Hoje estava 91, que é
Puxa vida.
30, 36, né? É
Sim,
91, é. Tá quente.
sim.
Tá quente.
Puxa vida.
Let's see,
Puxa vida.
91 divided by 5 times 9 plus, no. 91 divided by 9 times 5 plus 32. Não, estava muito mais que isso. 91 estava 37.
Deixa eu ver. Puxa vida, é quente, hein?
Não é que é o quente, sabe, Zé? É a umidade. The humidity is what is the problem. It's not the heat, it's the humidity. Esse
Sim.
fator é horrível, né? Você sai com uma jaqueta e já está sudando, né?
Sim,
Não tem maneira de sair confortável, não tem.
sim,
Mas
sim. E você, depois do fim do susto que você também
sim,
teve no coração e tudo, ó, tá
sim.
dando quase 33, eu converti aqui.
33? Tá bem, tá bem.
Você foi melhor na sua conta de cabeça, viu? Foi bem.
Tá quente, tá quente. Eu sei que
É,
tá quente.
tá quente, tá quente. Não, eu fui dar uma aula em São Luís, no Maranhão,
Sim?
no final de semana. E às 7h30 da manhã estava 32 graus.
Oh, my gosh.
Não, é muito quente, é muito quente.
Muito. E
Muito
umidade
quente.
também, né? Very humid.
Sim, sim, yes, yes. Não, é muita umidade. E eu devo ir semana que vem aí, Stanley. Semana
Você
que
veio
vem eu devo
para Flórida? Você vem?
para o Winter Garden.
Que bom, que bom.
Mas tá tudo bem.
Ficar uns dias aí?
Fica uma semana, uma
Fica uma semana.
semaninha aí. Eu falei, aquela vez que eu te liguei, eu conversei com o Bernardo está muito contente aí, tá muito feliz, coisa boa, né?
Ele vai
Bernardo,
ficar aqui ou ele vai voltar?
ele está com dificuldade de voltar, ele me falou, por causa que o visto dele, o passaporte, ele tava com medo de voltar para o Brasil e ter dificuldade no retorno do passaporte. Eu acho que ele vai ficar aí, viu?
Oh.
Acho que ele
Vai
não vai
ser
vir para...
professor? Que bom.
Nesses dias, ele não está conseguindo acertar o passaporte até agosto, que eu convidei ele para vir no Congresso, há tempo de ter liberdade para voltar. Então, é melhor, talvez, para ele ficar.
Por que as coisas ficam tão complicadas assim?
É
Né?
absurdo, né? Absurdo.
Eu visitei a página, I don't know how to say it perfectly in Portuguese, the web page at the Brazilian consulate, ok? Então, porque eu tenho 2 passaportes, um velho que tem a visa e o novo que não tem a visa, né? Então, liguei para lá, eu fui lá, é 1 milha daqui, né? Eu vou lá, você não pode entrar, tem que ter um appointment. Ok, me dá um appointment. Não, tem que fazer na internet. Ok, vou. Trato, não tem maneira. Então, eu ligo. Deixo mensagem. Por fim, liguei. Sim, senhora. Tá bem. Não, você não precisa visa para ir ao Brasil até outubro. Como? Como é isso? Não precisa, porque do COVID e isso e o outro. Tá bem. E não diz na página, no webpage? Não. Então, como é que o pessoal vai saber? Como é
que absurdo.
No, it's beyond comprehension. It's like, they send you to the site, you look at the site, and it talks about Lula, it talks about all kinds of things in Brazil, but it doesn't tell you that no visa required until October. I mean, it's okay. It's maneira de ser. That's it. How many people do we have on? We have 31. Wow! Espero que todo mundo também lá no Brasil e pode entender um pouco de inglês e espanhol e português, um portunhol, né?
Sim, sim, sim. É isso
Que
mesmo.
bom, que bom.
Stanley, vou dar mais uns 3 minutinhos, a gente começa às 8h10, pode ser?
Ah, perfeito, perfeito, perfeito,
Que,
perfeito.
que, que horas é aí, Stanley? 1 hora? Ou diferente?
7 e 7.
Tá. Muito obrigado, viu, meu amigo, por estar
No, no,
aqui.
lógico. No.
Você é
It's always a
fantástico.
pleasure, Zé. It's always a pleasure. It's a great honor to educate. It's a great ability to learn. And I hope to convey a very important message about doing minimally invasive surgeries from the standpoint of not having to do open decompressive laminectomies when we get into the mild procedure. But, you know, it's a mechanism of delivering the objective for the treatment. And that's the important aspect of trying to do the least disruption in the spine with the least harm, with the most beneficial outcome, and at the least cost, right? Because os gastos são incríveis, né? São incríveis. E os convênios não querem dar permissão para fazer esses procedimentos. But if we can demonstrate that it's cost effective and it saves reals and saves money, then we should at least explore that opportunity, right? We should explore it.
Yes, I know.
I wish the world...
Oi, Cecília.
Oh, hi, Cecília. Tudo bem?
Tudo bem?
Fantástico.
Boa
Thank
noite.
you for having me on. Thank you. Obrigado, hein?
Boa.
So how did Miles Day do? Did he talk about the what was he talking about? The hypogastric
base vertebral nerve
ablation. Okay.
Yes.
Yeah.
Yes.
Well, we have another.
He speak about Malbec.
Yeah, Malbec.
Malbec wine. Yeah.
The Argentinian wine. Okay.
Yes.
Yeah. Well, there's another procedure that we need to discuss in the next month or the month after, which is the discogenic source of pain that has a treatment similar to what the vertebrogenic pain is, but not with ablation. It's reconstituting nucleus pulposus and putting nucleus pulposus back in the nucleus pulposus. So,
really?
Yeah, we should discuss that.
Please.
Yes.
E mais no Brazil, when we go there, because this is an opportunity to capitalize on how to do this procedure and help millions of people without having to go through the huge expense of acquiring the company and so on. Yeah.
Let's do.
Okay.
Let's do it.
Yes. Stanley, eu vou fazer alguns comunicados aqui.
Lógico.
E daí nós já começamos, viu?
Tá bem. I'll go on mute. No problem.
No, it's okay. Thank you. Bom, primeiramente, queria agradecer a todos que estão aqui conosco. Na última segunda-feira do mês já ficou um encontro bastante agradável, todos os meses fazendo aqui o Pen Wine, e sempre com grandes surpresas, grandes convidados. O Stanley é uma pessoa maravilhosa. Muito obrigado, meu amigo, por estar aqui conosco. Eu, de coração, você sabe quanto você é importante e representa aqui para nós o Brasil, e você tem um pedacinho do Brasil no seu coração também, eu sei disso, né? Eu quero agradecer a Cecília, que está entrando com a gente. Ainda falta entrar o Alexandre Mil e o André Mansano, que vão estar conosco ainda à noite. O Stanley, você fez a sua formação, Stanley, ou trabalha em Melbourne? Como é isso? Ah, sim, só um minuto, desculpe. Um minutinho. Vou ligar teu som aqui, Stanley.
Zé, muito obrigado. Não, meu treinamento foi no Jackson Memorial, onde eu fiquei nos anos 86 até 89. Depois, eu fiquei lá como um professor fazendo anestesia de meninos de coração. Depois de uns 6 meses, eu fiquei um pouco chato, né? Estava fazendo a mesma coisa sempre e não queria, não tinha a maneira de oferecer. E eu pensei, eu podia dar mais de mim e meu entendimento de anestesia e também de dor. Por quê? Quando eu estava fazendo meu treinamento de anestesia, tinha um pain clinic no Jackson, mas muito pequenininho, muito pequenininho. E todos os dias eu ia lá tratar de aprender, mas só um fellow estava presente e ele tinha oportunidade e eu não tinha porque eu era só um residente. Mas chegou um dia, isso é uma história complicada, mas um minuto. Então chegou um dia que o professor disse: hoje você pode fazer tratamento. Que bom, vai ser legal. Vou fazer um epidural. Mas o paciente era uma senhora de 94 libras, uns 40 quilos, 45 quilos, e estava boca para cima. Então, eu não sei fazer epidural, pessoa supine, né? Isso é... né? Não. Isso é... Você vai fazer celiac plexus block. Como? Celiac plexus block? Oh, ok. Vamos no CAT scan. Não, aqui. Aqui? Como é isso? Pega a agulha. Bum, para baixo. Quando você sente pegar no osso, você está na vértebra L1. Oh, meu Deus do céu, isso não vai... Agora tira o stylete e sangue sai. Saindo sangue. Puxa, o que é isso, rapaz? Isso é maneira de fazer dor? Sim. Agora você vai pegar 50 cc de álcool e colocar dentro do 50 cc? Sim, você vai fazer um celiac plexus block. O que é isso? Essa foi a minha primeira experiência com dor. Eu não vou fazer isso mais.
Não, eu não sei como você foi para a dor depois desse tempo.
Coragem.
Nerves of steel. Mas eu passei meu tempo lá, então nós mudamos para Melbourne, fiquei lá 25 anos, fazemos um grande clínica, 4 oficinas, 200 empregados trabalhando por nós, 2 surgery centers, fizemos uma coisa maravilhosa para a comunidade e fizemos todos os tratamentos que podia fazer. Fizemos muita research com Abbott, com Medtronic, com Boston Scientific, porque quando eu comecei em 1989, só tinha 3 companhias, né, fazendo estimulação. Fizemos mais de 1000 bombas na prática. Foi um grande tempo, mas a evolução chegou ao ponto que eu vendi em 2015 e comecei a fazer research e comecei a fazer inventos, né, inventions para produtos, ajudando companhias para melhorar que eles têm existamente. And so I was a consultant for many companies.
Ok. Então, eu só me lembrei, só perguntei, porque eu fiz algumas maratonas ali. Tem uma baía bonita, né, em Melbourne.
Tem.
Bem.
Que bacana.
Quero agradecer, antes da palestra do Stanley, a OMED e a GenesMed, que faz o patrocínio, sempre o patrocínio da nossa plataforma. Quero convidar a todos para o nosso congresso, que vamos contar com a presença do Stanley Golovac aqui conosco também, de 3 a 5 de agosto, aqui em São Paulo, que vai ser o nosso congresso brasileiro. Também já temos confirmados Miles Day, Naruse, Sudir, enfim, mais de 20 convidados internacionais, então vai ser um evento muito especial. Hoje, inclusive, a todos os participantes, nós vamos sortear uma inscrição do congresso entre os participantes. E Também nós temos uma parte dentro do Congresso de temas livres, que eu convido a todos a participar, enviando temas livres, tá? E eu acredito que seja mais isso. Falei da inscrição. Golovac, muito obrigado pela presença. Você é uma pessoa muito querida. Por favor, fique à vontade para começar a sua apresentação e muito obrigado mais uma vez.
Uau, Zé, de meu coração a vocês e vocês todos que estão nesta plataforma, muito, muito, muito obrigado. E vamos primeiro falar um pouquinho de vinho e depois vamos falar para um procedimento que eu estou tratando de trocar a maneira de fazer o tratamento. Eu vou explicar como se faz em uns minutos, mas se me dá licença, vou falar um pouquinho em inglês, porque é um pouquinho melhor entender a maneira dos vinhos, mas if not, I'll say it in Portuguese, but I'll do my best. So, wine...
Por favor, fique à vontade.
Muito obrigado, né? So, wine is a great pleasure. It's a great communicator, and it's a great way to familiarize yourself with friends and people and to just have a great time with each other. And it's so individual because wine is something that you appreciate one way and not everybody appreciates in the same manner, which is great. So I don't know if you know the history of Napa, but I just wanted to give you a little piece of Napa. So Napa began way back in the 1860s, 1860s, né? And it was founded by 4 different vineyards. And those vineyards came to be, 5 different vineyards. And those vineyards were very important. It was Charles Krug, it was Beringer, it was Ingelnook, it was Hendry, and Schlumberg, which is a German family. They came to plant wines and they came to plant vines back in 1861. So bastante tempo that these vineyards were growing. And wine became such a culturistic way to express yourself because not everybody enjoyed it and not everybody appreciated it. So it was a way to have discussion. It was a way to start having an income, and it was a way to start creating a culture in the area, if you will. So the wine I'm going to discuss tonight is wine that I feel is what Napa Valley is, and it's Cabernet Sauvignon. I know that my dear friend Miles Day spoke about Malbec from Argentina, and I love Miles. I have the utmost respect for Miles, but I don't like Malbec. That's just me personally. That's no one else. That's just me. I think Cabernet is the essence of wine. And every day I learn a little bit more about it. And today's wine that I wanted to highlight is the BV Georges de la Tour 2019. So this was given a rating of 100, which is perfect, right? But, it's, again, an interpretation of what you like, because not everybody thinks it's the best wine for that year. Many people gave it a 98, a 97, but James Suckling, who is highly regarded, known throughout the world, gave it a 100. Something that I didn't know, and I don't know if you know, is that to be considered a wine and to be allowed to be labeled Cabernet Sauvignon, you don't have to be 100% Cabernet. You only have to be 75%. So many wines that you purchase and you say, wow, this is a great wine, and you say it's a Cabernet Sauvignon. Well, it may not be a total Cabernet Sauvignon. It may have Cabernet Franc. It may have Petit Verdot. It may have a blend of Merlot. So you have to read the label. The other thing that's very interesting in Napa is that there are 2 forms of how you can make wine. One form is to have estate-grown wine. So that means that you own where the vines are grown, you bottle it, you make it with your winemaker, and you sell it to the public. But not all wines are made like that in Napa. You can buy grapes from someone else, and that is also considered Napa Valley wine. What's also interesting is I can make wine and you can make wine. Really? And I live in Florida. How can you make wine in Florida? Well, you call the vineyard, you buy the grapes, you have them macerated, you have them put in barrels, you put your label on it, and before you know it, you get your bottle of wine, and you don't live in California, which is very interesting. So
yeah.
I think that, wine is a great expression. It's a way to complement a meal. It's a way to complement the conversation that you have with friends, that you have with family. And it's just a great mechanism on sharing a culture that I think offers so much to bond people together. So I hope you like Cabernet. I don't know if you do, but
I hope a lot.
Let's talk a little bit about it. Do you like Cabernet, Zach?
Yes, a lot, my friend.
Do you have any particular vineyard that you like very much?
Here in South America,
Okay.
we have one particular is a wine from
Fala em português, Zé. Fala em português.
the Zapata Winery.
Zapata.
Yes, the name is Nicolas. Nicolas Zapata is all Cabernet. Almost year. Muitas vezes ele coloca 90%, outras vezes põe 70%, outras vezes ele põe 100%. O Cabernet é um vinho é o bordolês, né? É o vinho que marcou a carreira aí do Robert Park, colocando os grandes notas nos vinhos.
Isso mesmo,
né?
Isso mesmo, sim.
Então é isso aí. É
It's
um vinho que agrada muito, tem corpo, é muito agradável, né?
But what's interesting about what you just said, in Bordeaux, the primary grape is not Cabernet, it's Merlot.
Merlot.
It's Merlot, right.
Yeah,
if you buy Petrus or you buy Le Ping, it's 100% Merlot. And these are very high category wines, right? And the first growth and the second growth. Something else that is very interesting to know about Napa is that Napa is a valley, uma valeia, né? But as you know, the wine concentrates itself by how hard the vine has to struggle to get water, which is very interesting. So there are 4 mountains that circle around the area of Napa called the Mayacamas mountain range. And the 4 mountains are very important. One is Mount Veeder, the other one is Diamond, the other one is Spring Mountain, and the other one is Howell Mountain. You know by the history that because the vines have to struggle, that the wine is more concentrated at the higher altitude. Okay, but what you don't know is this comes from Oakville, and you say, Oakville, huh? What is in Oakville? Oakville is the deepest part of the valley. And you say, wow, that means the water concentrates very heavily there. No, it does not. It drains because of the porous rock. So people charge a lot of money to buy grapes from those areas, specifically Tucalon, Tokalon. If you buy grapes from the vineyard of Tucalon, you buy the best. That is Harlan, that is Screaming Eagle, that is Cade, that is, oh my gosh, there's Bond, that they're very expensive wines, $1,600 a bottle. You know, this is $134, which for a 100 rating wine is very, very reasonable for the United States, not $1,600, because if not, every glass would cost you $400 to drink wine, right? Which is very expensive. So something that people don't know is that the wine comes from the different regions, and those regions are what people try to buy their bottles of wine from. So with that, I hope we didn't take up too much time. So I hope to raise a glass, thank everybody, and talk about our discussion of mild. But first, to George de la Tour, BV Private Reserve 100. So
Oh,
cheers.
very nice.
Saúde.
Cheers. Perfeito, meu amigo. Ótima conversa aí, viu?
Muito obrigado, muito obrigado.
Parabéns, você entende bem de vinho, gostei, viu?
You know, it's just I have 1,000 bottles in the wine cellar, and you know, it's just it's a passion. It's a great way to enjoy the evening with my wife and friends when they come over, and just open up bottles and just discuss and talk, and you know, just have a good time. You know, la dolce vita, right? You know, Zach, you know, life is very short. I know that.
I know.
You know
Yeah.
that I know that. And if you don't make the best of it, it may not be here tomorrow. So I'm going to ensure that I make the best of it every single day. So
Yeah. Well, we'll see. Obrigado, Golov.
So can you let me share my screen?
Yes, please.
Okay. All right. Here we go. Espero que vocês podem ver a apresentação. Podem ver o mild?
Yes.
Okay.
Yes. Estamos vendo muito bem.
Perfeito. So, me desculpa, but I'm going to have to do this in English because it's going to be impossible to make all of the references properly. I apologize. I'll answer the questions in Portuguese, I promise. So, minimal invasive lumbar decompression. Wow. It is a treatment that was designed in 2008. It originated for a cancer treatment of the spine. But they recognized that patients were developing a ligament that was overgrown, causing a compression of the spine. And it led to symptoms that we call neurogenic claudication: numbness, tingling, burning, heaviness in the legs and in the lower back. A debilitating problem for millions and millions of Americans, millions. So the thought was, how do you select patients? How do you confirm the condition? And how do you meet the expectations of patients and actually perform the procedure with minimal invasiveness and the most outcome of improvement? So the idea was to identify and to schedule patients as soon as possible, try to incorporate multiple studies. So we've done 13 studies at Virtus Medical, 2 RCT randomized controlled trials and effective outcome trials. We've developed an understanding of how to perform this procedure very simply, very efficiently as an outpatient, performed mainly by anesthesiologists and by physical medicine and rehabilitation doctors, pain physicians. There are orthopedic surgeons who do the procedure, and there are neurosurgeons who do the procedure, but they are very few. The company has not targeted those individuals, and they feel that the majority of patients who suffer with this condition go to see a pain physician and not a surgeon, at least in the country here. So we have over 2 million patients that suffer with this condition. And to this date, we've done 75,000 procedures since 2008. We've had 3 complications, 3, where we've had dural puncture into the thecal sac, causing CSF leakage that required suturing and required repair. But other than that, we've had no other complications in 75,000 cases. So it's an impressive outcome for the procedure itself. So what is neurogenic claudication? People sometimes don't understand, don't value it, and don't really give a lot of attention to a patient. So it's due to venous congestion. As you know, it's caused by the compression into the canal to the nerve root causing the area to become ischemic. That ischemia translates into numbness, tingling, and burning, heaviness in the legs. The patient can't walk distances, can't stand for long periods of time. So they come in with a walker, they come in with a cane, and they seek treatment. The standard has been to do an epidural steroid injection, but you know as well as I do that doing a treatment that is targeted at an inflammatory cause is not going to solve the problem. We know that. But the standards in this country, much like in Brazil, is to follow the algorithmic approach. So the whole crux of the problem is this large black ligament. The ligament enlarges, it compresses the spine, it creates a narrowing, and surgeons typically go in and remove the lamina, debulk the ligament, and create an open window. But is there a chance to do this from a minimally invasive mechanism? Is there a way to use tools? Is there a way to use instruments? Well, we believe so. We believe so. So the whole understanding of the canal stenosis is evident with 85% of the cases that you see have an enlarged ligament. So what is that? Well, the first thing to do is to confirm that the patient actually has the problem. So we perform a physical exam, we take a history, and we do imaging. If the ligament is greater than 2.5 millimeters, then you qualify for the procedure. Why do we think that you require this amount of ligament? Because Daniel Choi, professor at Columbia Presbyterian, said a small change in volume will equal a large change in pressure. So if you only have a small ligament enlargement in the canal, there's not enough pressure creating the ischemia that the patient may be complaining about. So there needs to be enough to be decompressed. It's like if you take a balloon and you put air in the balloon. If you only put a little bit of air, it's not so inflated. So removing some of the air does not remove a lot of the pressure. If you inflate the balloon and remove a small volume, it decreases a large pressure. So that's where the theory comes from, okay? So the target is this area in the posterior element of the canal, ventral to the lamina. We want to decompress the ligament that's causing the compression of the nerve root into the foramen, okay? So the patient comes in, confirm the symptomatology, perform an MRI or a CAT scan, or sometimes even a myelogram, and then offer them one of the treatments, which would be an epidural steroid injection, in order to help understand whether it's an inflammatory cause or it's a compression cause. So here in the United States, we do one epidural steroid and that's it. And then we go on to do the mild procedure. So we do physical therapy, we do conservative management, we do one epidural steroid, and then we do mild. We think that using treatments like the Superion that puts in a small implant is somewhat of value, but doesn't target the cause. Remember, the cause 85% of the time is the ligamentum flavum that is enlarged. So we really want to focus on that. This is probably one of the most compelling slides you're ever going to see. So the slide was created by Nagy McHale. This is a slide from the Cleveland Clinic, a very highly respected institution. So the patients would come in and he would ask them to stand, and they could only stand for 8 minutes. 8 minutes. Wow. That doesn't seem like a long time. And so after the treatment, they could almost stand for an hour. My goodness, that's a 600% improvement in their time. 600%. So then he would walk down the hall and say, let's go for a walk. And the patient could walk 246 feet on average. After the treatment, they could walk almost 4,000 feet. That's 1,500% of improvement. So you see, from a work standpoint or from a patient standpoint of being functional, You took an incapacitated patient and made them functional. That is monumental. That is monumental. With little recuperation, same-day surgery, no hospitalization, no administration of anesthesia other than local anesthesia, and this is the outcome. So this is a major compelling slide, major compelling. So I tend to, let me go back, sorry. I tend to not ask, and I know, não tenho a certeza no Brasil se vocês falam muito de VAS and pain scores. I think it's worthless, worthless. I think functionality is very important. I think learning to know what you can't do and what you want to do and what you are going to achieve to do is much more important than what's your pain score. Because patients will come in and say, oh, my pain is a 9.5. Wow, you look good for 9.5. I mean, I don't understand that. So we don't ask about pain scores. We ask about functionality. And we think that the numbers express themselves with improvement. The patients with stenosis, as you see here in the blue, have had the major improvement in their ODI at 2 years. 2 years, they continue to improve. So it demonstrates that the ligament, number one, does not regrow. Number two, it improves functionality. And number three, it restores the quality of their life. So these are the objectives that we try to measure. Now, we always ask ourselves, are there cofactors and comorbidities that can also improve? Obviously, yes. Many of these patients have bulging disc, herniated disc, they have foraminal narrowing, they have facet hypertrophy because of the overgrowth of the joint, they have degenerative disc disease, and they have disc height and loss. All of these will add to the complications of the pain syndrome that the patient talks about. So how can this affect that? Well, again, we go back to Daniel Choi. A small change in volume equals a large change in pressure. What's causing the problem is not the degeneration. What's causing the problem is not the facet hypertrophy. What's causing the problem is the ligament. So if you decrease the size of the ligament, you increase the blood flow. You increase the blood flow, you take away the symptoms, the patient becomes more functional. So this is one of the great understandings of how you can theorize and improve a condition from minimizing the treatment and maximizing the reduction in pressure. So the 2-year outcome study demonstrated that with mild, we saw no fractures occurring, even with patients with severe osteoporosis. There was no device that was implanted, which meant that there was no potential for the device to move, for the device to dislodge, or for a fracture of the transverse process and the spinous process to occur. So this was an added element that was beneficial to understanding. We took a study and looked at 27,000 patients at this time period. We looked at how the overall improvement was from the outcomes and the objective. And we saw that 88% of the patients at 5 years were completely satisfied. So within the kit are these instruments. We have what we call a bone rongeur. We have a tissue sculptor. We have a base plate. This is called the trocar, and this is the portal. This is what we use actually as the depth gauge in order to not go beyond the depth of where we want to go. So the portal has a little mechanism to stabilize the actual area on the base plate. And once it's in place, it does not move forward or backward. So the size of the opening that is created is the size of a baby aspirin, uma aspirina pequenina, né? At 5.1 millimeters. That's the whole opening that is created by the portal. So it's very small, very small. And the objective is to try to take away this enlarged ligament, leaving the ventral fibers, leaving that area to preserve the integrity into the canal. So the objective is to remove the thickened ligament. Now, sometimes it's challenging, right? The lamina is overlying the other lamina, so you have to flex the spine, but there are some tricks to how to do that. So this is what the trocar looks like. There it is entering the spine. We go just medial to the pedicle, just medial to the pedicle. And we go in first with this instrument, which we call the bone rongeur. The bone rongeur goes in and takes a bite of the bone and hopefully a bite of the ligament, tries to detach the ligament. So this is the portal, as you see. The portal rests on the lamina. Now this view is different. This view is called the contralateral oblique view, or the CLO. So we like to use this view because it gives us an understanding of the lamina and allows the portal to rest right on top. Once that's in place, we use the imager to intensify what the ligament looks like. So we flip the scope on the opposite side, and we use that to target where the image needs to be. So the needle goes in and debulks the ligament, So are there risks? Of course there are risks. The risks are the same for any procedure that we do fluoroscopically. Inadvertent durotomy, that we puncture the dura, nerve root damage that can occur if you're too aggressive with the instrument. Postoperative hemorrhage is unlikely, but should it occur, it's very superficial. Remember, the actual instrument never goes beyond the laminar line. So you're never inside the canal. You're never going to compromise and cause an epidural hematoma. You may have blood in the soft tissue, but never in the canal if you respect the anatomy. And obviously infection can occur because if hygiene and sepsis are prone to the patient hasn't been in a clean environment, you didn't use an aseptic technique, you didn't give preoperative antibiotics, then an infection could ensue, but it's, again, unlikely. So on the back table, we have a few things that we provide, and that is a scalpel to make the simple incision, a needle for the epidurogram, gauzes, drapes, instruments to help identify and hold the area, and then we prepare the area with the patient lying on a carbon fiber table, not an OR table. And the reason is when you create that contralateral oblique, you don't want the bed rails to be in the way. So you want to be able to have a carbon fiber table that allows you to image through the patient's body and through the table itself. So this is a very controversial slide. It's controversial because after 75,000 cases, we have figured out that an epidurogram may not be necessary. And you say, what do you mean it may not be necessary? You want to see a debulking, you want to see an improvement, you want to see the flow change. We haven't been able to prove with all these cases that a dynamic flow change improves the outcome. What do you mean? Well, we looked at thousands of cases of where we created a new technique called the streamline technique, where we did something called defined bites. What is that? We go in with the bone rongeur, we take 3 bites on the superior lamina, we take 3 bites on the inferior lamina, and then we go in with the second instrument called the tissue sculptor. We go in and take 3 bites and we're done and we're finished. We don't sit there and try to remove more and more and more. We do 3, 3, 3, and the procedure is done. With that, the patient's outcomes were the same. We didn't find that there was a significant improvement by removing more ligament. So we've now abandoned doing an epidurogram. Some physicians feel comfortable. I don't. I think that if you respect the posterior laminar line, you don't need to do an epidurogram, but that's me. That's my choice, and everyone does it differently. So this is one of my cases where you can see the needle, you can see the epidurogram. This area here is the ligament that's enlarged. You can see the flow of contrast goes superiorly, and the objective is to debulk the ligament and improve the flow. That's the objective. So typically we draw lines on the body showing where the pedicle is, where the spinous process is, and where the pedicle is. That is, again, somewhat unnecessary. So we call this here shingling. We call it one lamina on top of the other. So in order to open the lamina, you have to flex the spine. I mean, all of you know that. So by flexing the spine, you can open the area of where you're going to decompress and debulk. The objective is to open this area so flow can go superiorly. We know that 90% of the time, flow goes cephalad and not caudad, right? So the lines are drawn, we put in the trocar, the needle with the epiduralgram is in place. I can see the posterior laminar line. This is the instrument called the portal and the trocar. Once it's in place, we put on the depth gauge. The depth gauge is a safety mechanism. We turn it down to approximately the 5 millimeter mark. So that way, when the instrument goes in, it doesn't go beyond the area of the trocar. So the portal and the stabilizer stay as a unit. It holds in place, and then we go in with a tissue sculptor. So this is what I've been working on. I don't think that this is the optimal instrument to do this procedure. Why is that? Because this looks like a scooper for ice cream, para correr sorvete, né? Para correr gelato. Se você pega esse instrumento e coloca dentro do ligamento, você está empurrando o ligamento anteriormente. Você não está pegando ele. Então, eu fiquei olhando, e eu disse, isso não está correto. Como é que eu podia melhorar ele? So I looked at what we call a spork. I made a fork and a spoon. So now when you go in, the ligament goes through the tines, and now you can get more of the ligament to decompress. So we're working on that at the present time. So you go in first with the bone rongeur. The bone rongeur goes in. As you can see here, it takes a bite of the actual ligament and takes a bite of the bone. Nagy McHale did some work on cadavers after we did the procedures. And the most important part was not actually debulking the ligament. You say, what do you mean? That's the objective of the procedure. No, it was detaching the ligament. If you detach the ligament, you loosen its attachment to the origin and the insertion. So if you loosen it, you take away the pressure. And that's exactly what the bone rongeur does. It takes away the ligament attachment, taking away the pressure inside the canal. So once you are able to get underneath the lamina, you grab a bite and come out. And then you do the same inferiorly. You grab a bite and come out. The next part of the procedure is to debulk and take away the ligament. So this is the tissue sculptor. You can see the teeth are open. You go in, you grab a bite, and you retrieve. You go in, you grab a bite, and you retrieve. So you're trying to sweep and debulk the ligament in the area on the left side, and then you switch to the opposite side and debulk on the right side. Again, the objective is to remove this part of the ligament, removing the thickened area of the ligament with this tissue sculptor, right? So you can see here now, the tissue sculptor goes in and it's going to remove that area and decompress the ligament. That is where you have to get underneath the lamina to try to remove those fibers that are causing the compression. So once we used to use the epiduralgram as a pre and post, but we did not find the correlation. We thought that if the ligament was pushing in, we should see a straight line of contrast, but that didn't work out. It didn't dynamically improve to the point of overall improvement, and it took much time in performing the procedure. So we abandoned that. This is a ligament pre. As you can see, it's indented, and this is contrast afterwards, of which you can see the flow. Again, we are not using that. At the end of the procedure, we remove the entire portal and we put steri-strips, and this is ligamentum flavum that is removed from the procedure. It's quite a bit. It's about 3 to 5 cc's in order to remove that amount of quantity. So when a patient typically comes in the office, we call this the grocery cart sign. The patient comes in leaning over their walker, leaning forward to open the spinal canal. We know that that improves the function, and if they sit up or extend backward, it causes more pain. It's some of the questions that we go through. So when we look at the ligament and we look at the actual MRI, we can see here on the left, this is normal. This is very mild. We would not do the procedure here. We would only do it for the moderate and moderate to severe. Once it's gone past the severe compression, it's beyond hope and probably won't improve. So this is the ligamentum flavum. As you know, this is enlarged by 2.5 millimeters, and this would be an ideal candidate. Here's another patient showing the ligament that's enlarged. The canal is wide open above, but compressed with a disc bulge at the site of L4. So that's the area that we would be treating. Here's another patient that has 2 levels, L3 and L4. And again, very much the target of where you want to try is those ligaments that are 2.5 millimeters and above. So sometimes patients come in and they have a pars defect, or they've had a hemilaminectomy. Sometimes they have instrumentation or an f-stop in between. Sometimes they have spinal cord stimulators. Sometimes they have pumps. You know, patients present with all sorts of different issues and complications. Sometimes they come in synovial cysts, which has to be decompressed and has to be removed, and then perform the mild procedure. But that doesn't mean that this is not a candidate. So again, when we look at this particular procedure, we want to try to identify the actual ligament itself. So here is an axial view of where we see the ligament, and here is the sagittal view that correlates to the compression of the ligament at the same level. That is what we're trying to look for. So these images help to reinforce what we're trying to identify, which is the ligamentum flavum that is hypertrophied. So I hope you enjoyed what we discussed. I hope you will ask questions and we can go and try to identify anything that you have to ask. So, muito obrigado para todos, hein? Muito obrigado.
Parabéns, viu, Gola? Maravilhosa apresentação. Eu já vi essa apresentação sua e você sabe que eu sou fã do procedimento. Deixa eu tentar ativar alguns colegas a mais aqui da mesa. Deixa eu ver aqui. Tá aqui o André, o Alexandre Mil. E vou ativar o Gabriela. Vou ativar seu som também.
Vai lá, Gabriela, vai lá. É sobre o vinho ou sobre o procedimento?
Sobre o procedimento agora. O vinho já ficou maravilhoso.
Mas podemos falar mais do vinho, mas não. Tô brincando.
A Sandra está aí também, obrigado, viu?
Obrigado, hein?
Oi,
boa aqui, Andrezão. Ô, Stanley, deixa eu te perguntar uma coisa aqui. Eu conheci esse procedimento lá com o Boscher, na Texas Tech, há uns 10 anos atrás, mais ou menos, aí. E eu já fiquei encantado com o procedimento. E eu sei, você conhece muito bem os donos da companhia, são amigos seus, se tornaram mais próximos. Aí você já tentou, inclusive, trazer o procedimento para o Brasil.
Sim.
Eles são uma companhia ainda pequena, apesar de ter um volume muito importante nos Estados Unidos.
Sim.
E sempre parece que comercialmente, na verdade, eles estão esperando o momento de serem adquiridos por uma companhia maior, que daí vão para o resto do mundo, vamos assim dizer, né? Enfim, então nós temos aqui o sonho. Eu já tentei conversar com eles várias vezes, você também. E uma das perguntas que existe é o seguinte: como o procedimento ele é feito com raio-x em contralateral, né, como você disse, é o contralateral view,
Uhum.
o oblique, contralateral,
Oblique,
você tem uma exposição de radiação importante para o executor. Essa é uma das críticas ao procedimento, né? E eu queria entender um pouco o que você vê, isso é um problema mesmo, se vocês conseguem contornar isso. E eu achei muito interessante que você não faz mais o epidurograma, que classicamente é a descrição, né, do epidurograma. Você não faz nem quando você termina, meu amigo, só para... Então,
Não.
eu queria
Vai.
dividir em 3 perguntas. Se há esperança para o Brasil e se você entende essa radiação aí como sendo realmente um problema, né? E o terceiro, como que você chegou à conclusão de não necessitar do epidurograma?
Tá bem. So, vamos falar dos 3. Eu vou levar instrumentos para nós tratar de...
Por favor.
So, eu vou levar. Okay.
Perfeito.
Okay, so that's question number 1. The radiation was a big question, and that's why we trocamos do sistema convencional, o streamlined approach, de fazendo the determined aggressive bites and not trying to remove, inject, remove. That was exhausting and very exposed to the physician with radiation. Agreed. That being said, I'm totally covered. You know, I wear glasses, I wear gloves, I wear a sleeve. I'm totally covered. But even then, now we've changed the whole procedure. So the procedure can be done in 5 minutes total, and maybe 2 minutes of radiation. Maybe. Number 1, you put on pulse. Number 1, it's not live fluoro. Number 2, you go in and grab and pull. Done. Grab and pull. Done. And then you remove 3 bites of the ligament and you're finished. With all the cases that we've done, we didn't see a significant difference in doing an epidurogram, removing, and doing the defined bites. The outcome was the same, because a small change in volume equals a large change in pressure. You don't have to remove a big ligament. That's number 2. Number 3, if you know your anatomy, and you know your anatomy, okay? You're not trying to prevent the instrument from going beyond the anatomical line. If you see the anatomical lamina and the instrument never gets to the lamina, you are never going to be in the canal. Never. So why are you doing an epidurogram? Many physicians here in the United States, they struggle to get the epidurogram. 45 minutes, an hour, 2 hours, because the lamina is tight and they can't get in. So they get frustrated. The patient is very frustrated, and the case never comes to completion. So at the company level, and myself and others, we said, listen, stop doing the epidurogram. If you want to do the epidurogram, okay. You want to do it? Okay. Go below, because the contrast goes up. If you can't get in below, go caudal, go in the sacral hiatus and put a catheter and use the contrast that way. There are many ways of accomplishing the goal, but it's not necessary as that. It's not necessary. So we looked at thousands of cases, and the outcomes are very similar. It's all about just decompressing a large ligament to take away the pressure. Not a small ligament, a large ligament. That's the understanding there. So I hope I was able to answer all three.
Muito bem.
Ok.
Obrigado. Pessoal aí,
Ligamento
por
amarelo.
favor, perguntas para o Stanley aí.
Sim, sim. Há resultado tirando apenas o ligamento amarelo. Oswaldo, o que você quer com essa pergunta? Não estou entendendo.
Provavelmente, Stanley, existe sempre a dúvida se a hipertrofia da faceta, a parte óssea, também é responsável. Eu entendi que você colocou como indicação primária do procedimento a hipertrofia do ligamento.
Sim.
Né?
Com mais de 2,5 milímetros.
Com mais de 2,5 milímetros.
Sim, sim. E a hipertrofia, the hypertrophy of the joint is a cause, but that's a fixed factor that you and I can't change because I'm not doing a facetectomy. You can do it, but that's an open procedure, right? So what is the common denominator to treat the ligament? Now, if you treat the ligament and you take away the pressure, the joint stays enlarged, but we don't feel that that's the cause of the canal compression. It may be the foraminal compression, but not the central canal. And we think, and we've proven over and over and over, that if you decrease the pressure within the canal, it translates to the nerve root. That's what we believe.
Mil.
Não, eu fiquei impressionado com os resultados dele, né? Os resultados do professor Bola são impressionantes. Né?
Alex, é interessante, nós fizemos um estudo agora mesmo que não apresentei, de 5 anos depois, 5 anos, né? 88% dos pacientes estão satisfeitos e só 2,4% tinha cirurgia depois. 2,4%. That's it. 2,4% went to have surgery. 88% were satisfied with the outcome. That's monumental. That's monumental.
É impressionante. É isso que me desculpe, mas é uma quebra de paradigma, porque eu acredito que a seleção dos pacientes deve ser muito bem feita, porque a estenose foraminal, né? A estenose foraminal não será afetada. Então, é preciso ter um cuidado muito grande para que a seleção seja feita para os pacientes com estenose central.
Sim.
Essa que é a questão. E a conjugação de estenose, da estenose central com a foraminal é muito comum.
Sim.
É muito comum.
E tem uma maneira que eu te pode demonstrar que você leva o instrumento mais lateral, não tão lateral, porque não pode chegar no foramen, né? Não pode, mas deixa você chegar mais superior na lâmina para tirar o ponto máximo que você pode aceitar saindo do foramen. Não vai ser perfeito, but from a minimally invasive procedure, this is ideal because it's ideal. I mean,
eu gostaria de pedir ao senhor para, quando vier ao Brasil, em agosto, o senhor fazer para nós no cadáver. Teremos uma, né, Zé? Teremos aí uma.
Não, ele vai fazer.
Não, eu quero ver esse procedimento ao vivo, porque
é maravilhoso.
É impressionante. Né? Me impressionou a facilidade do procedimento, a rapidez, a facilidade, né? E o resultado, né? Fiquei impressionado com os seus resultados. Eu gostaria de poder reproduzi-los.
Well, I'm working with a French company well, forget about the French company. Let's find a Brazilian company that we can duplicate the instruments and recreate what needs to be done in order to help so many millions of patients that all of you treat. Because I will help you. I'll help you do that.
Very good.
Thank you, Professor.
Okay.
Pode ser com seu tissue sculpture novo. With your new one.
Fork. That's
fork. Yes.
Oh boy.
Maybe we're going to learn with the right one.
Yeah. I've also I'm selling to Abbott, to St. Jude, a new lead and anchor that I think needs to be improved also, but that's another story. And then we'll talk about the discogenic disease problem too. So we have a lot to talk about in August.
Yes. We wait for you in our Congress, my friend.
We're going to be very busy. We're going to be very busy.
Yes.
But Stan, you better bring good wine. If you don't bring good wine, I'm not coming.
Two more questions.
More questions? Yeah.
Yes.
Tem uma pergunta aqui da Rosana, de Brasília, falando que o ligamento amarelo em geral está muito aderido à dura mater.
Sim. Mas
o fato de puxá-lo, se não aumenta a chance de fístula dural. O que eu tenho entendido, eu não sei se você está dizendo a mesma coisa, você simplesmente afina o ligamento, não é importante você retirá-lo completamente, é isso?
Não, lógico. Eu estou preservando o ligamento ventral e essa parte que eu não quero tocar. Eu quero só tirar o parte que está hypertrophied, não? Para tirar essa porção do ligamento para
uma descompressão.
Luiz.
Oi, Gabriela.
Oi.
I've never seen a fistula. Hey, como é que tá, Gabriela? I've never seen a fistula. Tudo bem?
Tudo bem, Stanley. Saudades. Como é que você tem?
Igualmente.
Um prazer te ver, que honra, viu?
Obrigado.
Mas faz todo sentido, né? Porque você retira o ligamento amarelo num paciente idoso, e esse paciente ele já não tem muita mobilidade. A função do ligamento amarelo é mais para manter essa estabilidade que ele já vai ter, porque ele tem uma artrose das facetas, ele já não vai ter um movimento exagerado, não é? Então, assim, a ideia é maravilhosa, né? É maravilhosa. Surgiu em 2008. Eu tive a oportunidade de usar só uma vez em cadáver também. Acho que foi um
Você veio aos Estados Unidos aprender?
Faz tempo. Em 2008, por aí, 2009. Eu achei fantástico, né? E aí lembro daquela entrada, né, que eu brinco contralateral, mas não chegou nunca no Brasil, né? Vamos ver se agora o Zé Luiz, que é como presidente, consegue aí encabeçar, porque vai ser muito bom, né?
You know, the laws of patent infringement only affect the people in the United States. There's nothing that we can't do in Brazil and duplicate and alter what is the actual device and change it just a little bit and make it Brazilian. You know?
Yes.
Tem jeito, né? Tem um jeito, tem que... Os brasileiros ajeitam a tudo.
Andrezão, tem alguma pergunta aí, meu amigo?
No, not a question, just to congratulate him.
Muito obrigado, André.
I missed the wine lecture.
Oh, well, hey,
you
missed a great bottle. This is BV Private Latour 100, okay? This is very good.
Very good.
But I didn't miss the second most important part of the lecture. So,
Right.
I previously know the procedure once in Miami, and of course it's wonderful, especially for a clinical scenario that the remaining interventional techniques are, well, not that good. It's not that good. The other techniques.
Yeah, you know, I mean, if you have the opportunity to do something like this that can offer a significant improvement in symptoms without a major potential open surgical decompression, you know, the answer is why not? Why not? The value of what you get for what you pay is huge. If it doesn't work, there's no harm. Then you go to Bernardo, you go to Zé, you go to yourself, and you have a laminectomy done, and you remove the rest. But if you can make somebody significantly better, your mother, your father, your brother, your sister, by doing this procedure, then, I mean, come on. You know, I mean, I'm involved in many companies, and, you know, we talk about augmented intelligence now. It's becoming the understanding of diagnoses to be able to figure out what patients suffer with in a second, like that, where you and I, we can't. We have to think, and we ponder, and we figure it out, and it doesn't happen. But AI does it in a second. So why not use technology that can help improve a patient who's your family member, my family member, and make them better by doing a procedure like this? I mean, it's the evolution of time. It's the evolution of time.
Yes.
Mais uma pergunta do marceneiro.
Sim.
Pode ser feito em mais de um nível? More than one level?
Oh, yeah. So that's a great question. So the answer is yes. You can do 2, 3 levels, 4 levels, and even 5. Okay. But the question is more so, what level is causing the problem? Okay. You can do it. I've done 5 levels, but what level is causing the problem? So that takes understanding. I like to do selective nerve root blocks. No steroid, local anesthetic, 1 level at a time of where I believe the problem exists, because the patient is going to tell you L3, L4, L5, L2. When you do a selective nerve root block, just a little bit of anesthesia and it's done, the patient gets up, walks, and says, "Oh my God, I feel great." Or no, it's still there. Well, then you need to go to the next level. But you can do 4 levels. You can do 4 levels. Yeah.
O Stanley,
Very smart.
uma pergunta, viu, Stanley? Desculpa,
Sim.
Mil.
O que é?
Só para deixar claro na indicação que nós estamos entendendo, lógico, a causa do espessamento do ligamento amarelo e até uma estenose de nível moderado, né? O que seria uma estenose absoluta já teria indicação cirúrgica ou até endoscópica. É isso que você está dizendo?
Lógico. You know, yeah, exactly. So severe, you're not going to make a significant difference because it's probably calcified. It's too compressed. You're not going to remove enough ligament to make a difference. It's much like a degenerated disc, right? So if the disc is flat, you're not going to offer a treatment to that. I mean, you're not going to help that. If the disc is beginning to lose its height and you re-inject the area, then it's like a tire, uma goma, pneu, né? Se a goma está perdendo ar e você coloca ar, se infla. Mas se o pneu está completamente perforado, vai ser difícil. So severe stenosis does not show significant improvement. It's mild to moderate.
Perfeito. Mil, desculpa aí.
Não, o que eu queria saber nos Estados Unidos, qual o custo desse tratamento?
O custo o custo do actual produto é $1.500. Não é caro, não. It only costs, they charge $1,500. They get paid $2,500 for the procedure in the surgery center. The kit only costs $100. The kit costs $100. Same dollars. Mas I didn't say that. But they charge $1,500. I didn't say that.
Perfeito. Tiagão, quer abrir o som aí, Tiagão?
Boa. Ele não falou nada. Não está gravado, Zé. Nós vamos apagar a gravação.
É verdade. Quer abrir o som aí, Tiagão? Aí.
Nada,
bem-vindo,
Thiago. Hey, buddy, how are you?
Working.
Well, it's about time. It's about time you work. What are you doing?
Yeah, I know.
What are you doing? Craniotomy?
No, I'm gonna do a mild Sorry.
Oh, that's good.
Yeah.
No, if I could, I would. No. I end up on call here.
Okay.
Excelente aula, como sempre. Só para seguir para dar
Hey,
um
Thiago,
falar
what
de
a
novo.
pleasure. What a pleasure to be able to express, this with everybody and, share knowledge and share, good wine and just enjoy each other. So I hope to see you in 3 weeks, no? In
Yes.
2 semanas.
2 semanas, yes, for sure.
Que legal.
See you, my friend.
Tiago, faltou você estar com o vinho aí no centro cirúrgico, né, meu amigo?
Nossa, cara.
Eu acho que não pode não, Zé. Não pode não. Escondido.
Tá certo.
Mas não
Tudo
pode
bem.
não.
Tá bem. Pessoal,
Obrigado.
querem fazer mais alguma pergunta aí?
Come on, you people. You should be asking question after question after question. Come on. There's 53 people on the call today, Zé. There's 53 participants.
Yes.
More than 70.
More than as usual, my friend. You are great every time.
I try to deliver. I hope to give you my passion with what I do. I hope to see everybody there at Indoor in Brasilia, or if not, we'll see each other in São Paulo with Zé in August. I'll be there. We'll launch the book, which is wait.
Que figura.
Yes.
Launch the book. Yeah. Thiago's name, right? Bernardo and mine. Well, everybody get a copy.
Yes.
This is a great book, and we have 2 more books coming, right? Where'd Thiago go? He left. Okay, we have 2 more books coming, but yeah, this is a great time.
No.
Muito obrigado por tudo. Muito. Um abraço grande. Espero ver vocês já pronto, hein?
Tá bem, meu amigo. Obrigado por tudo.
Obrigada.
Viu?
Boa noite.
Ótima noite aí. Obrigado.
Boa
Muito
noite.
obrigado.
Só um minutinho, pessoal. Eu vou falar o sorteado aqui. Desculpe aí. Temos a inscrição aqui. Só um minutinho. Foi a Lise Ramos Costa Doreia de Alencar, de Maceió. Ganhou uma inscrição do Congresso da Sobre a Mídia. Tá? Parabéns
legal.
aí.
Parabéns,
Valeu,
Lise.
pessoal. Boa noite.
Obrigado, Zé. Obrigado, pessoal.
Tchau.
Grande abraço.